Well, this is cardiology program. I use a fair number of speakers as well. It's probably one of my favorites because I think I can add a little something. So today we're excited to have Dr. Ruchi Kapoor, who is a professor in the division of cardiology with our backgrounds. Ruchi is a local talent. She attended the University of Washington with a Bachelor of Science in Neuroscience and also a Bachelor of Science in Engineering. She then moved to the East Coast where she attended a very prestigious MD PhD program at Cornell, where she studied lipid membrane biology and effects on channels. Unfortunately, she's not talking about that today. No. She then came back to the West Coast, did her Charles Medicine residency at UC Irvine, followed by cardiology fellowship. And we were lucky enough that combination of Dr. Eugene Yang and her parents recruited her to join the division in 2019. And I've got to know her since then because she does clinics at Eastside and we work together. She is a great clinician, and I'm lucky that when I'm in clinic, she's there and balance up ideas. I have to say it's more, I'm usually more bouncing out, but she's a great clinician. She's also a great educator. We have fellows on Thursday afternoons for the last 3 years, and I've seen her teach with a very busy clinic. Besides being a great clinician and teacher, she also is a great advocate. She is a board member of the Education Future Cell, was the president last year. She's an expert in women's health and cardio-oncology, and we're really delighted to have her speak to us today. And I'm looking forward to learn about this topic that I think is very important. Thank you.
Thank you so much, Fareed, for that wonderful and very kind introduction. And thanks also to Eugene for getting me here today. So I just want to say that, you know, all those degrees and prestigious universities don't help us do technical management, but thank you to Doan for helping me set this up. So I have no disclosures today, and I just wanted to give a very brief, abbreviated outline of this very complicated topic, or at least I think it's very complicated and broad. And we're just going to concisely review it today in 3 components. What is syndrome X? Understanding its very basic pathophysiology, evaluating coronary, how we evaluate coronary physiology, and how we treat this disease process. Yeah. And so I wanted to start off, as usual, with a typical patient story. At least it's typical in my clinic, where a 43-year-old woman referred to me for chest pain. She has family history of familial hyperlipidemia and chronic sinus tachycardia, but really no other prior health issues, no hypertension, no hyperlipidemia herself, no diabetes. And she tells me in clinic that she's had this sort of long-standing intermittent chest discomfort, tends to happen with exertion or stress, but it's really not been so severe or prolonged or bothersome, so she tends to just ignore it. Just FYI, this patient is a physician herself, so I feel like that's a little bit, unfortunately, typical of us, that we tend to ignore it, our own symptoms. But anyway, so she came to me because last week she was speed walking up a hill and noticed this chest tightness that took a while to go away. And since last week, she's noticed it a little bit more often. She noticed it while playing with her kids, while walking in the hospital, or with any kind of stressful event. And now it's also, she's noticing that it's taking a little bit longer to recover from this chest pain. She's a never smoker, no significant alcohol use history. And then the other interesting thing that she told me while in clinic is that, you know, as I was walking here, I was speed walking a little bit, and I actually got some chest tightness, and I have some chest tightness right now. I was like, well, that's great. Let's get an EKG. So on the top, I show you her baseline EKG from like 6 years ago. It's pretty normal. There's some waviness in the baseline, but no significant ST changes that would suggest ischemia. But while she's in clinic with me and complaining of chest pain, we see some ST depressions in her inferior leads and in her anterolateral leads. We keep talking. 15 minutes later, her chest pain resolves, and we repeat another EKG, and those ST depressions are gone. We just did a mini stress test in our clinic by virtue of having her sit there. And took, as she said, it took her a long time to recover because the ST depressions aren't completely gone away. But 15 minutes later, this is what we have. And so I ordered a workup, got an echocardiogram, no cardiomyopathies, no valvular disease. The echo is very normal. And then because she's young, relatively healthy otherwise, we opted to go for a coronary CT angiogram. And here's a representative image of her LAD, and there was no coronary artery disease for her. So she essentially is a 43-year-old woman with effort angina and essentially a positive stress test in clinic with me, and normal echo and no coronary artery disease. These are the sort of the classic syndromes that are called Syndrome X. And it was first coined in 1973 by Dr. Harvey Kemp from Columbia, and he wrote an editorial about the paper above. Myocardial function during atrial pacing in patients with angina and no normal coronary arteriograms. The reason the term came about is because in the study, they divided the patients into two groups, the ones who had the normally coronary angiograms, and that was group X, and then the group that had obstructive coronary disease, that was group C. And from there, Dr. Kemp sort of broadened it to characterize sort of all these patients who, mostly women, who had chest pain and normal coronary angiograms. And it was really, Syndrome X was really characterized by what it was, what it wasn't. It wasn't obstructive CAD, which is sort of what all our focus had been traditionally. And there was even debate about whether this truly constitutes as ischemia or not. So for a long time, this was actually just considered to be a psychosomatic issue in women until we got more objective evidence, like my patient who had ECG changes during her symptoms, or there were other biomarkers or poor perfusion or perfusion defects themselves on imaging tests or on echocardiograms. So then they said, okay, fine, it's not, we'll call it ischemia, but it's not real heart disease. We'll call it microvascular angina, but it's still pretty benign. So not a lot of investigation was done. It was a bit of a mystery as to what it constituted, what it exactly was. So they did call it microvascular angina because it obviously wasn't macrovascular disease. And then the Women's Ischemia Syndrome evaluation group came along, who took a cohort of women from the late 1990s from all over the US who basically had typical symptoms of angina. Some of them may have had a positive stress test, or some may not. But all of these women were, for some reason, indicated for a coronary angiogram. And so they looked at 936 women, and of those, 42% had obstructive coronary disease, meaning all these women with typical angina symptoms, majority of them, almost 60%, did not have any coronary disease. Quite a bit of them, like 59% of the remaining 60%, had no CAD at all, and approximately half, 41-ish% of the remaining group had some non-obstructive CAD. So that's the group that they really wanted to look at, was the ones with the symptomatic women who had normal coronary arteries versus the ones who had non-obstructive CAD. And when they compared these two women, or groups of women, they find that they had differences in MACE, in adverse outcomes over 5 years. And they also compared the women who had no coronary disease, normal coronary arteries, but symptoms against women who were asymptomatic. Of note, these asymptomatic women did not have any angios, but still assuming that, you know, no symptoms versus symptoms and normal coronaries, there was still, this is what the p-value is for, there was still some adverse outcomes there. So the WISE study was the first time that we showed this is not entirely a benign disease process. There are poor outcomes that happen. Most of these poor outcomes were related to hospitalization for heart failure or stroke. And then they went and took a slightly deeper dive into let's risk stratify all these women based on their risk factors. How many risk factors do they have? If they have 0 risk factors versus more than 4 versus 2 to 3 in between. And the lightest gray bar here are the women who were asymptomatic. The slightly darker gray are the women who had normal coronaries. And then the black bars are the ones who had non-obstructive disease. So obviously there is a difference in cardiovascular event rates that happen the more risk factors you have. And then they also looked at them based on age. And this is actually what I thought was one of the most interesting points. The patient that I presented earlier, she would fall under this category of age under 48, which is the typical group that's dismissed, like they're there, you don't have any problems. This is just all sort of in your head, but maybe not, but it's still benign. And here we see that between asymptomatic and symptomatic women with completely normal coronaries, there's a significant difference in outcomes over 5 years. This is not a benign disease. Okay, so what is it? What is the syndrome X? So to kind of go into it, I'm going to take us back to our sort of basic physiology and pathophysiology days. Here's a map of a coronary circulation. Traditionally, we've looked at just the epicardial arteries. That's what we look at when we do our coronary angios or coronary CT angios. And the main function of the epicardial arteries here is transportation. They have both the epicardial and sort of the arterioles here have that classic 3-vessel wall. The intima, that's endothelial cells, the media, which is the vascular smooth muscle cells, and the adventitia, which is sort of the fibroblasts and connective tissue part. And all those are implicated in how the coronary blood flow adapts to changes in physiology. But most of the adaptation and regulation really occurs in this pre-arterioles and arterioles portion of the coronary tree. And this is what's constituted as a microcirculation. And particularly this sub-100 micron group of arteries, these intramural arterioles are the ones that are responsible for oxygen matching and responsive to metabolites, changes in metabolites, and really mostly responsible for regulation of coronary blood flow. To assess, we don't have a good way of looking directly at these arterioles unless you think about things like slow flow phenomenon on coronary angios. But we then need to find a way of looking at coronary blood flow in those areas and assessing changes in that and how that regulation is maybe altered in these patients with syndrome X. But I'll get to kind of the assessment portion in a little bit. But going back to what is microvascular microcirculation function versus dysfunction, at any given time, our microvasculature is a balance between vasodilation, vasoconstriction, and that's really dependent on our endothelial pathways and endothelial independent pathways, which are more poorly characterized. The endothelial dependent pathways are a little bit more investigated and better understood. And so in microvascular dysfunction, what ends up happening is that either we have an increase in vasoconstricted properties of our coronary system, or there's a failure of vasodilation in response to appropriate responses. Either way, the end result of this kind of change in balance is ischemia. Some of the major molecules that are implicated for vasodilation, nitric oxide and endothelin-1 in vasoconstriction. There's very good evidence that it's dysregulation of these two molecules and sort of the downstream pathways and upstream pathways related to these that are implicated in microvascular disease. This was a paper from our very own Dr. Bacchus and Dr. Kim, who do a very nice review of what constitutes endothelial dysfunction. On the left here, we have a healthy endothelium that's releasing nitric oxide from this eNOS, which is an endothelial nitric oxide synthase enzyme. And the enzyme responds to laminar flow, it responds to acetylcholine, to insulin, to really release nitric oxide, which in turn leads to vasodilation, anti-inflammatory, and antithrombotic properties. When there is dysfunctional endothelium, the eNOS gets uncoupled, so we have now a decrease in nitric oxide production. We have an increase in production of reactive oxygen species. The permeability of the endothelial layer is increased, so we have now influx of macrophages into the tissue. And overall, it's just a state of increased inflammation. And what can lead to it? A whole host of things. The typical risk factors that we think about for coronary artery disease also impact endothelial function. Smoking, hypertension, viral infection, diabetes, obesity, and LDL. There's additional pathways that I'm not really going to discuss, but this is usually the center stone of what we consider to be dysfunction in microvascular disease and what is investigated when we do our coronary physiology assessment. So how do we do the assessment? The most comprehensive way is still doing an invasive coronary angiogram. And usually we have to, before we can assess the microvascular or coronary blood flow in the microvasculature, we have to first rule out epicardial disease. We do a part of that rule out process when we say these patients don't have any obstructive disease, but if we give them acetylcholine and they have endothelial dysfunction, they can also get vasospasm, epicardial vasospasm like you see here, where there's nice normal flow here and then that LAD artery almost disappears. Once we've assessed that and we reverse it with nitrates, intracoronary nitroglycerin usually, we can move on to assessing the endothelial independent pathways, where we usually give some kind of a vasodilator like adenosine or another vasodilator that causes hyperemia. And while we're doing that, we measure coronary flow, coronary velocity in the distal segment of the artery. Sometimes just the LAD is sufficient, but there's some studies that look at RCA versus LAD versus circumflex because it's not homogeneous. And so once we measure coronary flow, you can either do that directly with a Doppler, or you can do thermodilution in the LAD. You can calculate coronary blood flow you measure coronary blood flow at baseline hyperemia. You can calculate coronary flow reserve at baseline versus hyperemia. And then you also determine index of microvascular resistance. And abnormalities with those constitute abnormalities in microvascular flow. The other aspect that's being investigated more and more is microvascular spasm. So we evaluate for macrovascular spasm by this visual assessment of coronary cross-sectional area after acetylcholine. But there's also the possibility that these patients might be having spasms in that microvascular bed in which we can't visually see. And one way to do that is, okay, first you rule out the epicardiospasm, and then if they still have the typical ECG changes and angina symptoms with the acetylcholine, you diagnose them with microvascular spasm. Or you can very infrequently in the studies out there, but some places you can do direct measurements of coronary blood flow with a Doppler as you're giving acetylcholine. And then, but does this actually have any long-term implications? How does this correlate with outcomes? And that's where we go back to the WISE group, and they did a study where they looked at cardiovascular events with adenosine. And you see that for women who had poor coronary flow reserve, that's less than 2.32, they had more events, cardiovascular events, over a span of 10 years than women who had normal coronary flow reserve. That's the endothelial independent pathways. They also looked at women who had coronary blood flow changes in response to acetylcholine. So again, not the macrovascular spasm, but we're talking about the microvascular spasm. And we also see a difference in outcomes, but not as significant as the one with adenosine. There was another group that wanted to, international cohort that wanted to look at not just women, but men and women. Most of the patients that are enrolled in this are from Japan, but also Australia and a few other places. And they had very strict definitions of who was enrolled. They defined microvascular angina symptoms, no obstructive CAD, and they define how they define no obstructive CAD, and impaired microvascular function. How they define microvascular dysfunction, they had, again, very strict criteria, either decreased coronary flow reserve in response to adenosine, increase in microvascular resistance, microvascular spasm, or slow flow phenomenon on coronary angiography. And again, they also show that these patients have increased incidence of major adverse cardiovascular events over time, but most of these events are driven by unstable angina. And you can see maybe a little bit of a trend with cardiovascular death, but mostly by angina. There are additional components of coronary physiology that we can assess with invasive angiograms. So those are not part of any of the standard definitions, either with the WISE group or the Covadis group. And that's, for example, just measuring FFR over the entire coronary artery. And even though there's not a single obstructive lesion, if the FFR is less than 0.8, then it means that there's diffuse epicardial disease. That could be a component of what we traditionally consider microvascular angina. And then the one that we don't talk about too often, another one of those, there, you have it, it's not a problem, go away, is myocardial bridge. And that's best sort of, I mean, you can visually assess it on coronary angios, but that's really more formally assessed by doing an intravascular ultrasound and looking for this sort of half moon sign where during both systole and diastole, where you see external compression from this myocardial bridge. And the group in Stanford by Dr. Trammell did this sort of a little bit more comprehensive coronary evaluation in 2015. Again, these are 139 patients with angina, no obstructive CAD. They may or may not have had abnormal stress tests. So none of that objective evidence always for ischemia that we're looking for. And they define microvascular disease dysfunction as a resistance greater than IMR greater than 25. And what they find is that, you know, you take these all comers of, again, classic syndrome X, and of all of those comers, maybe 20-ish% of them have no abnormality. Majority of them have some form of dysfunction on their coronary physiology assessment. Majority of them are myocardial bridge, but then there's some with endothelial dysfunction, meaning that a response to acetylcholine, microvascular dysfunction, as I discussed, in response to adenosine, low FFR, meaning sort of just diffuse epicardial disease, and the bridging, as I mentioned. Not everybody has the resources to do that kind of coronary physiology assessment in their cath lab. So we want to also look at what are some non-invasive ways of looking at microvascular physiology or coronary physiology in general. And one of the more common ones is cardiac PET, or maybe not common, but certainly one of the best validated, where the beautiful thing about cardiac PET is that in addition to just looking at perfusion defects, you can actually also look directly at myocardial blood flow. So on the top there, they have the first patient here is somebody who has normal, these are stress images, no perfusion defects. Their myocardial perfusion reserve is pretty normal. Normal is greater than usually 2 or 2.5. Here's a patient, again, classic syndrome X patient who had symptoms. Their myocardial flow reserve by cardiac PET is reduced 1.15. But again, no perfusion defects that you see on the images themselves. And then another person who had those classic syndromes and their perfusion reserve is normal and no defects here. So they compared, and here's a myocardial blood flow, and what they find is that normal subjects respond appropriately to a vasodilator, and same with patients who had at the onset a normal NPR and then low myocardial reserve. You can see this where they give them a vasodilator and there's not much change in their myocardial blood flow. When we look at the perfusion reserve, normal versus all comers, it's slightly decreased, but then we want to look specifically at the syndrome X patients here. And what we see is that the biggest difference is really between the normal patients and the ones here between with the decrease in perfusion reserve. The point that I wanted to make here is that you can have abnormal myocardial blood flow and perfusion reserve in the absence of perfusion defects. So you don't always have to have an abnormal stress test to see a dysfunction in microvascular space. And syndrome X is very heterogeneous. It includes patients who have this decrease in blood flow versus not. By cardiac PET, they also showed that these individuals who had poor coronary flow reserve had worse outcomes, regardless of gender. So this is not just a women's disease. Not every place has the resources for cardiac PET, and certainly cardiac PET has CT radiation with it. Some places can do cardiac MRI and look at stress perfusion and semi-quantitative assessment of myocardial blood flow here. And so here's a normal patient who has, you can see their subendocardial to all the way to epicardial wall is lighting up very nicely during stress images. Somebody who has multivessel coronary disease, you don't see that myocardial wall lighting up. And then somebody who has microvascular dysfunction defined by abnormal index of resistance, you see that there is patchy lighting up, and most of the decrease in brightness is in the subendocardium. And again, this correlates with symptoms and abnormal coronary physiology. This is a little bit more challenging. So if you don't have a cardiac PET machine, you don't have a cardiac MRI, which is really a lot of times at sort of academic institutions with that kind of assessment. Most places do have an echocardiogram, and you can assess coronary blood flow by Doppler if you can find that LAD artery, in the distal LAD artery in particular. And you can measure Doppler flow at velocity or the VTI there during diastole and compare it at rest versus hyperemia, and can diagnose somebody with microvascular dysfunction there. In this particular study, just recently, they did a cutoff of abnormal flow velocity of less than 2 is flow reserve is abnormal, and they tried to correlate it with abnormal flow reserve in cardiac PET. The correlation is pretty darn crummy. So, and this is also very technically challenging, being able to find that tangular artery, making sure that you measure the Doppler precisely and in that exact same spot between rest and hyperemia. So technically challenging, not the greatest correlation with what's considered to be the gold standard for non-invasive testing. And then the last thing I wanted to talk about is kind of where we started, which is stress testing. And this was, again, a just pretty recent study where they wanted to see whether stress tests, echo with treadmill or with dobutamine and stress ECG, whether they're predictive of microvascular dysfunction or just coronary flow dysfunction. And they looked at 155 patients who had angina, who underwent stress tests and coronary angio. Again, no obstructive CAD. And the sort of outcome is that generally stress tests are poorly predictive of who's going to have microvascular disease or coronary flow abnormalities. If you look, most of these odds ratio confidence intervals cross 1. The only things of note are the stress ECG, our most basic stress test, does tend to correlate with endothelial dysfunction. And if you start including more factors like the total number of METs achieved or their heart rate achieved or blood pressure response, et cetera, if you kind of do a more comprehensive evaluation of that stress test, and maybe tends to be a little bit more predictive. But stress tests, abnormal stress tests are not always predictive of microvascular dysfunction. So going back to the original point that I made is that, you know, we have angina, we have no obstructive CAD. Do we really need that abnormal stress test to say this is not in your head? No. The chest pain guidelines that Dr. Gulati has sort of been on the championing women's heart health issues and was an author on the chest pain guidelines in just a couple of years ago. They do look into this. They finally do take into account and acknowledge all these patients who have stable chest pain and no obstructive CAD based on either invasive or CT coronary angios. And they do recommend then doing further testing. It's not class 1 indication, class 2, but you can do invasive assessment if you have that capability at your institution. It's a class 2A, or you can do stress imaging. Based on the data that I just showed you, stress PET tends to be, or CMR tends to be preferred over echo. But when you're doing invasive coronary testing, they recommend, of course, doing acetylcholine, again, to look at endothelial-dependent pathways, and some other kind of vasodilator to look at hyperemia, to look at endothelial-independent pathways. And they say, okay, if your coronary flow reserve is normal and you don't have increased resistance with hyperemia, basically you have N-negative provocation to acetylcholine, no spasm, then this is a non-cardiac chest pain. But if you have spasm and or that reproducible chest pain or ECG changes with acetylcholine, then you have vasospasm. If you don't have that spasm, but you have the abnormal myocardial resistance, increase in resistance with hyperemia, or a decrease in coronary flow reserve with hyperemia, then you carry a formal diagnosis of coronary microvascular disease. We can't do this level of comprehensive testing with cardiac PET or cardiac MRI because we can't do that provocative testing with acetylcholine. So we can't rule that out. But if you see somebody who has reduced myocardial blood flow reserve, then they carry the diagnosis of coronary microvascular disease. All of these diagnoses are great, but what do you do? What do you do with these patients? And that's somewhat been a holy grail in this field. And for the longest time, of course, you know, it's hopefully I've convinced you at this point that it is a heterogeneous entities and not one therapy is going to work uniformly. So for example, here was a study in 1999 who looked at 10 patients with angina, positive ECG stress test, and no CAD. And they did this amazing test of, let's look at our standard anti-angina therapies. Let's look at amlodipine, atenolol, and isosorbide mononitrate. They randomized the order. They gave these patients these drugs for 4 weeks at a time, and saw that really of all these all-comers of syndrome X, no coronary physiology testing here, atenolol seemed to improve the symptoms the best. There was another one in 1989 that looked at 16 patients with angina, ST depressions, and no CAD. And here they decided to assess daily ischemic episodes by Holter and evaluating whether they had ST depressions or not. Interestingly, not every patient had chest pain that correlated with ST depressions, but also not every ST depression correlated with angina. That said, they decided to look at ST depressions, and propranolol reduced the number of times they had ST depressions and the magnitude or of duration of ST depressions in these patients. Diltiazem. So we've not shown anything with amlodipine. We haven't shown really anything with verapamil. Let's go for diltiazem. And here they did look at coronary blood flow and coronary flow reserve. And they gave them adenosine, or not adenosine, but another vasodilator, 16 patients who were undergoing coronary angio anyway. And what they find is that, okay, so normal coronary flow reserve, not that microvascular dysfunction, diltiazem does nothing for them. But also diltiazem nothing for them if their CFR is low also. So for endothelial independent pathways, there doesn't seem to be any benefit to giving them calcium channel blockers. There was another group pretty recently in 2022 that wanted to look at diltiazem again and do a sort of more comprehensive assessment of looking at acetylcholine versus adenosine, endothelial versus endothelial independent pathways. And what they show is that there is no improvement in coronary function test results with diltiazem, whether it's just looking at spasm or microvascular dysfunction. They saw no improvement in angina symptoms or quality of life with diltiazem. And they counted a treatment success if there was normalization of any aspect of coronary function testing, and diltiazem didn't really help there either. But one thing they did find is that if at the beginning of the study, at the beginning of the acetylcholine provocation, there were patients who had epicardial spasm. If they gave them placebo, their repeat acetylcholine provocation made no real difference. But for the patients who were on diltiazem, more of them changed from epicardial to microvascular spasm or no spasm, but mostly changed from epicardial to microvascular disease. So diltiazem maybe helps with epicardial disease. Going beyond the traditional medications that we use, they also looked at metformin, but this was an odd study because they looked at not at coronary microcirculation, but they looked at subcutaneous microcirculation with hyperemia. And metformin seems to improve some microvascular perfusion here, but it also tends to improve more clinically important ST depressions during exercise tests and tends to improve angina symptoms. We look at ACE inhibitors, and ACE inhibitors also seem to improve coronary microvascular resistance and flow reserve, particularly though with acetylcholine assessed flow reserves and resistance, more so than placebo. But enalapril also clinically important, noted to reduce anginal attacks, and these patients were able to exercise a little bit longer during stress tests. There was a different group that went and looked at coronary flow reserve, and same thing, they improved coronary flow reserve here to 2.6 to 2.7, and the change was significantly different. There's a future trial that's going to look a little bit more comprehensively at this. This is looking at clinically stable women with no CAD, and either doing intensive medical therapy with statins or PCSK9 inhibitors, plus ACE or ARB, and versus usual care. And they're going to look at outcomes with this treatment. Ranolazine, it tends to improve certainly angina and quality of life symptoms. And when they looked at using cardiac PET, myocardial perfusion reserve resistance index, it tends to improve that. Ranolazine more than ivabradine improves angina and ischemia, but not necessarily coronary blood flow here. And then when they did ETTs on these patients, they find that, I mean, ivabradine did improve their time before they got ST depressions, but ranolazine had more profound effect. And then there was a third study that's like, ranolazine, what do we do with it? Okay, there was no difference in angina symptoms when they looked at, again, 22 patients. This is after treatment for 12 weeks. And they looked at coronary flow reserve, and there really wasn't any difference there. But then if they looked at subgroup between, okay, let's look at people who actually had really poor coronary flow reserve, less than 2 versus greater than 2, then they start seeing some effects here, and improvement in symptoms also. The idea, again, there being that maybe we need to do a better job of doing that coronary functional assessment and really selecting for the patients who have really abnormal microvascular dysfunction. Sildenafil improves coronary flow reserve based on but the effect is more profound in people who have CFR less than 2.5 at baseline. And dapagliflozin, so now we're getting into sort of more of our current day therapies in heart disease and heart failure. And so here, these are the stress images of myocardial blood flow, cardiac PET. These are the rest images, and this is the flow reserve calculation, which is a ratio of these two. So initially, the flow reserve was 1.82, abnormal, placebo didn't significantly change. This group, for some reason, this particular patient example that they used had a flow reserve of 2.4 prior to dapagliflozin, but then after they did 4 weeks of that therapy, they had significant improvement in flow reserve. And we see that here. There's some novel therapies that are being developed. As I said, there were some other sort of vascular dysfunction pathways that we didn't really discuss beyond nitric oxide. Rho kinase pathways involved, and there's a drug, Fasudil, that's an inhibitor, prevents microvascular spasm. Endothelin A receptor antagonist also improves coronary blood flow. And then there's a very nice review article a couple of years ago that goes through sort of all the other trials, studies that are maybe supportive of certainly PCSK9 inhibitors and endothelin receptor antagonists and a few others. But the question that we always come back to in cardiology is, do these therapies actually help with outcomes in the end? Everything that I've shown you so far is really about symptoms or ST depressions or coronary flow reserves. What about outcomes? This is the only trial that we have to date. The CorMicA trial, 151 patients who had angina and were undergoing routine angios and didn't have any coronary disease. And at that very moment in the cath lab, they randomized them. And they all underwent coronary flow assessment with acetylcholine, adenosine, but then they put like a cover over the screen so that the doctor who referred them couldn't see the results. And based on the investigation group was really the results of the coronary physiology testing was revealed to the patients and to the doctors. And then there were treatment recommendations that were made. versus a control group that still underwent that physiological assessment, that data, that information was not released to the patients or to the treating providers. And the treatment plan that they recommended. So first is no obstructive disease. Obstructive disease was the exclusion criteria. And if you first do a physiology assessment with the adenosine and you see, okay, they have their physiology assessment by adenosine is normal, so CFR greater than 2, and IMR, the resistance is less than 25, normal microvascular function. But then they gave acetylcholine and you see vasospasm. So vasospastic angina. They really primarily recommended calcium channel blockers, nitrates, or lifestyle changes, which really we should be doing for everybody, and smoking cessation, again, should be doing for everybody. Then there was a group that had coronary microvascular dysfunction. Their coronary flow reserve was less than 2. Their resistance was greater than 25 in response to hyperemia. And they did not have any endothelial dysfunction in response to acetylcholine. For these patients, they recommended beta blockers. There's some evidence that the third generation beta blockers, which is nebivolol and carvedilol, they tend to work a little bit better. Nebivolol tends to release nitric oxide. And as you know, carvedilol alpha blocker, there's some vasodilation with that. So those beta blockers tend to be better, but any beta blocker plus lifestyle changes and consideration of ACE and statin. And then the third group was where there was normal invasive physiology and no vasoreactivity testing. They said, stop all anti-anginal disease or therapies, discharge from cardiology, and consider non-cardiac causes of chest pain. So for them, this is most of the, again, very similar to what I've shown before. About 8 to 14% of patients had normal physiology, but all the others had some kind of abnormal coronary physiology. And they found that patients where the information was released to the treating provider and to the patient, they tended to have better angina symptoms. And then they also, this was, I thought, very interesting, was they also interrogated or questioned the treating cardiologists who had referred these patients for coronary angios. And pre-randomization, they really didn't feel very confident of their diagnosis and maybe thought that it was related to coronary disease. But after randomization, certainly the physicians who were given the information from the physiology testing said, yes, my patient has coronary dysfunction. They were more certain of that, and they were more certain of the patients who didn't have coronary disease. It really changed the attitude of the treating physician, knowing that data and knowing certainly what the treatment recommendations were. We don't have information on long-term outcomes from that, even though that's kind of how I set it up as. Ultimately, coronary microvascular disease is just one component of syndrome X. There are structural issues, like in epicardial disease, we talk about structural mechanisms like the myocardial bridge or the traditional plaque model that we talk about. Functional disease of the epicardium, including spasms. That's not often talked about, but the only way to really assess that is with provocative testing. And then when we get into microvascular mechanisms of ischemia, we, again, didn't really talk today about structural mechanisms, which can be related to hypertrophy, amyloidosis, capillary rarefaction, obstruction, or remodeling. And then functional mechanisms is really what most of the focus has been to date on either impaired vasodilation or enhanced vasoconstriction, whether it's related to endothelial dysfunction versus non-endothelial smooth muscle cells hyperreactivity. And so this is kind of what I want you to take away with, is that syndrome X is very heterogeneous. There's epicardial disease. There's microvascular disease. We have a little bit of information about how to target to these specific disease processes, but certainly more data is needed. And these can be also implicated in or other pathologic components that can be implicated in syndrome X are myocardial bridge, hypercoagulability, infiltrative diseases, vasculitis, pain, inappropriate pain perception, which is what the sort of in your head component was in the past. So in conclusion, patients with syndrome X or angina, ischemia, INOCA, really constitute a heterogeneous group of individuals. Their coronary dysfunction, you have to rule out obstructive CAD first, so you can assess coronary dysfunction, but can be differentiated based on endothelial reactivity versus endothelial independent, and epicardial versus microvascular. It is not benign and is associated with adverse outcomes. Management options is complicated evaluating that because most of these studies have patients that are like 10, 15 patients, have different techniques in assessing coronary physiology, and have variable definitions of what constitutes microvascular disease. And CorMicA study is sort of the one study that we had that demonstrated benefit of subtyping and doing a targeted treatment plan, hopefully with improved outcomes in the long term, but certainly improvement in symptoms. Ultimately, we don't quite know where to go at this time and moment, but more data is forthcoming. But in the same paper where Dr. Harvey Kemp coined the term syndrome X, he did say that, these heterogeneous patients where we sort of know, where we don't know what's going on, these observations are like the clues in the first half of an Agatha Christie novel. Big fan of mystery novels. They may not be readily understandable, but we can certainly be sure that they are important in determining the long-term sort of plan for these patients. And I mainly wanted to give a huge thank you to Dr. Kathleen Kearney. She's our interventional cardiologist here at University of Washington, who does all of our invasive coronary physiology assessment. She does the provocative testing and hyperemia responses, and is always a great person to reach out for to discuss, hey, I have a patient, I don't quite know what's going on. They have some abnormal test results, some don't, and discussing the next best step and interpreting those results. So huge shout out to Dr. Kearney. Thank you.
That was just an outstanding talk, very comprehensive.
Thank you.
I'll start the questioning. So you presented data that the patients who have adverse outcomes. I guess, what is the pathophysiology of their adverse outcomes? What are they? Do we know that? Because most of the studies are focused on symptoms, but can you comment on that? So
yeah,
we want treatments beyond just symptoms.
Yeah. So the one of the I'm not going to scroll, but one of the outcome studies looked at sort of the subgroup analysis, found that most of the improvement or adverse outcomes was really related to unstable angina. And then one of the other, I can't remember, I think it was the WISE group one, that showed that it was related to stroke and heart failure. And I thought that was actually pretty interesting because what I don't go into in my talk is that we believe there is a strong component of microvascular dysfunction in patients with stress cardiomyopathies. And I have a patient in clinic, I didn't include her images, but she had a stress cardiomyopathy event when she was giving a eulogy. They did a coronary angiogram, no obstructive disease. And on the coronary angio, they did an LV gram and they found the Takotsubo. A few months later, her echo had completely normalized, but she was still having symptoms. She did a stress test. There was appropriate augmentation of her LV function, but she was still having symptoms. So she came to me for a second opinion. We did a cardiac PET on her, and her myocardial blood flow reserve was abnormal. particularly at the apex in the area where she previously had that. So I think I do wonder if some of the outcomes that we're talking about is related to maybe stress cardiomyopathy and vasospastic angina, things like that. But we don't have great data. I mean, that's kind of the best that we have.
Sure.
Yeah, that was a really nice review of the comments. So when you were going through the drugs, you didn't have nitrates.
I had one. It's we use, and it's, you know, it's funny because nitrates are not all patients respond to nitrate, and they don't respond all the time to nitrates. And you're right, I didn't really talk about it because it is that where, let's see if I can find it was the very first one. This is it. This is the data that we have, 10 patients. Yeah, 10 patients, made no difference in symptoms. But I think, you know, in sort of I kind of blew past this slide, but it does come into play when we talk about epicardial endothelial independent pathways and how much of a improvement in cross-sectional area of the epicardial artery we get with nitroglycerin, intracoronary nitroglycerin. So it is a component of assessment that we can do, but there is not great data that it's of how much of this is related to syndrome X. Thank you.
I guess my big question is about patient selection for sending into invasive testing. I'm very surprised at some of the patients that get some data who end up with a positive test because they're often it's very heterogeneous. Patients have atypical or possibly cardiac or even non-cardiac symptoms, and they get sent with positive. So I'm still on the first step about who we should select.
Oh my gosh, that's like the big elephant in the room. And I don't have a good answer for you. I think if I can get by on an answer with non-invasive testing, then I do. What I'm finding, you know, for the example, for that patient with the stress cardiomyopathy patient, she just found it, I just saw her last Friday. She just found it so reassuring to know that it wasn't just in her head. And we're trying IMDUR and we're trying amlodipine, and actually I'm probably going to switch her to nebivolol. It's my go-to beta blocker now for these patients. And hopefully her symptoms will improve, but she at least, I think the most that I'm getting from this kind of physiological testing, whether invasive or non-invasive, is reassurance of the patients. And who knows, maybe that's just enough to improve their symptoms in the end. But I think there are some patients out there who I try empiric therapy, I try the non-invasive testing to see if there is any improvement in symptoms, not necessarily testing, because as we saw, you don't have to have an abnormal ETT or stress test to have microvascular dysfunction. So I really just go by symptoms, and if empiric treatment doesn't work, or I'm getting very confusing results, as some people respond to amlodipine for a little bit, but then they don't, and then they do okay with nebivolol or don't. I don't quite know which bucket of syndrome X they fall into. Then I will refer them to Kate Kearney for further testing. But usually I find that it takes a little bit longer with trial and error. I have another patient who had normal coronaries and has had angina symptoms for the past year. And I've been working with him since springtime on, first we tried IMDUR, that didn't work. We tried amlodipine, he said that didn't work and stopped it for a while. We went up on the dose, worked, didn't work, don't know. I just started him on nebivolol and he's doing much better. But I think if I had at the onset just sent him straight to Kate for testing, I suspect we would have found that he had probably an increased IMR or a decrease in CFR, and then I could have done targeted therapy a little bit sooner. So the short answer is, I mean, I don't send every patient for invasive testing, but where I'm running into a little bit of a roadblock in figuring out what's going on, whether treatment is maybe they don't have coronary, abnormal coronary physiology, those are the people that I send to her.
Ruchi, Dr. Linker asked something similar. You answered that. So let's move on. Dr. Thompson is asking, is forearm vascular resistant testing still being done?
So it's a little bit of kind of what I again didn't include that. It's not being done now. It used to be a marker of, or except it's done in like research studies. But it's a marker of hyperemia. You inflate and then you kind of look at how quickly blood flow returns. And I think if possible, cardiac PET is a little bit better and more indicative of coronary physiology rather than peripheral microvascular disease.
Great. Just want to take this opportunity to thank Ruchi and all the audience in person. I want to thank you very much.
Thank you.